and also the chairpersons for the kind introduction. I welcome everybody. Also for the 11th and 12th March, we are organizing a national level meeting, updates in oncology and hematology in Kanpur. And coming back to the topic, it's the role of immunotherapies and its sequence strategy in the management of head and neck squamous cell carcinoma. When we look at the global burden of head and neck cancer, India ranks the top most. As you could see, the number of the new cases that we can see in the Globocon data of 2020, the oral cavity is nearly 10.3% of the data. And that figures keeps on increasing at an alarming rate every month and every year. And if you have to look at the projected numbers, you can see at those astronomical figures of around 45,000 male patients in 2025 for a tongue cancer, 15,000 patients for females for the tongue cancer, and similarly 65,000 for the mouth cancers and 25,000 for females for the mouth cancers. And these figures are just a projections. With the consumptions of the habits we have at an alarming rate in this part of world, I believe these figures are going to exceed in much larger numbers. And when we discuss the numbers, we also discuss the stage at which they present. As compared to the Western population, our population is very, very different. We don't find those localized or local disease. We find most of a very local regional disease, that's 68.2%. And also most of them do present with distant metastasis, nearly 27%. So very aggressive biology, very brutal presentations. And if you look at the relative proportions at which they present, you look at those figures, most of them are 3/4 above for the males and the females, especially at the presentation of these facially disfiguring cancers. And we have to look at also the type of the treatments which we do. Surgery is something which is very reserved in terms of, because the disease is predominantly loco-regional or distant metastasis, where the surgery has a very limited role. Systemic therapy do play an important role, and it's where the multimodality treatment that's going to be very, very important, especially the induction chemos and followed by the triple modalities, the surgery and radiation. So looking at the picture at what comes and looking at the data as what it was, if we look at the extreme trial, the median overall survival with whatever the best regimen we had with the chemo targeted agent, be it the platinum 5-FU, be it the platinum 5-FU cetuximab, or the platinum 5-FU and taxanes based combinations, I believe we couldn't reach that figure of 12 months also. 8 months was the median overall survival that could have been achieved with the extreme regimen. 2022 was a revolutionary year when we had this introduction of first-line preferred regimen change with pembrolizumab, platinum 5-FU combinations, that is cisplatin or carboplatin, as a category 1. Pembrolizumab single agent for tumors expressing PD-L1 with a CPS of more than 1, category 1 if it's a CPS of more than equal to 20. And the cetuximab combination came as a other recommended regimens, cetuximab platinum, it's cisplatin or carboplatin 5-FU regimens. Also in the second line, if the immunotherapy wasn't being used, it was being used as nivolumab if the disease progressed, or a pembrolizumab if the disease progressed on and after platinum as category 1 regimen. And this came because of a keynote 48 data, which was presented in ESMO 2018, a phase 3 study of the first line pembrolizumab, a very fairly simple design. Again, if you look at the eligibility, all those patients who have oropharynx, oral cavity, hypopharynx, or laryngeal cancers, who are relapsed metastatic disease incurable by local therapies, and they were stratified based on whether they were PD-L1 positive, that is TPS score of more than or equal to 50 or less than 50, the P16 status in the oropharynx, whether it was positive or negative, the ECOG performance status as it was 0 to 1. 3 regimens were chosen. Pembrolizumab was given 200 milligram every 3 weekly for up to 35 cycles. Pembrolizumab plus chemo. The chemo backbone was 3 weekly regimen for the cisplatin, 100 milligram per meter square, 5FU, 1000 milligram per meter square for 4 days, carboplatin AUC 5 for 6 cycles, and then pembrolizumab was given as maintenance. The third regimen, which was the control arm, was the standard cetuximab, carboplatin, cis-5FU combinations. Carboplatin, again, AUC 5, cisplatin, 100 milligram per meter square, 5FU, 1000 milligram per meter square for 4 days. Carboplatin or cisplatin based on the physician of the principal investigator and the physicians of choice, followed by cetuximab maintenance every weekly for 250 milligram per meter square. So the primary endpoint was in the stratified groups of CPS more than 20, more than 1, and total population OS and PFS. The secondary endpoints was again in the CPS more than 20, CPS 1, and total populations, the PFS rates at 6 months and 12 months, the overall response rate, and also the quality of life assessment by the EORTC score, that is C30 and head neck 35. The key exploratory endpoint was the duration of response. If we look at the number of the patients, 882 patients were randomly allocated, and 300 were treated with pembrolizumab, 276 were treated with pembro plus chemo, and 287 were treated with the extreme regimen. And with a median follow-up of around an year, that was a fair distribution of the patients. If we look at the baseline characteristics, be it age, sex, performance status, PD-L1 status, or whether it was a metastatic disease or a recurrent disease only, they were fairly stratified between the pembro versus the chemo group. And if we look at this, the pembro versus the cetuximab group, if we look at the CPS score of more than 20, you could see again the progression-free survival. The Keytruda had a median PFS of around 5 months as compared to 3.4 months with the extreme regimen. With the CPS of more than 1, again 5 months PFS was there. If you look at the long-term follow-up, the hazard ratio was 0.81. So immunotherapy is based as on the principles that those who respond, they keep on responding, and that's where the curves doesn't touch the baseline. As you could see in the extreme regimen, the curves were just touching the low-lying Ganga water plains. But yes, you could look at 48-month rate, 6.6% were surviving with the extreme regimen, while 15.4% were surviving with the pembro regimen. If you look at the median overall survival, that's around 11.5 versus 10.7 months. But if you look at closely the hazard ratio, it was 0.8, meaning a 20% reduced chances of deaths when you give in all the population the Keytruda for the same. If you look at the subsets as which subset it benefited, if it was CPS more than 20, you could look at the magnitude of benefit was much, much higher. In the total population, it was hazard ratio was 0.8. In the CPS more than 20, it was 0.61, meaning there was a 40% reduced chances of deaths when you give Keytruda as compared to the extreme regimen. So again, if you look at the overall survival, it's 15 months versus 10.8 months. And if you look at the 48-month benchmark, again, 8% of the patients were surviving as compared to 21.6% of the patients who were surviving in the pembrolizumab group. If you look at the CPS more than 1, again, pembrolizumab was raising the bar with a 16.7% long-term figure of 48 months as compared to 5.9 months. And again, the hazard ratio was 0.71, meaning a 30% reduced chances of deaths when you give Keytruda. Not only it was responses, not only it was survival, it was also the duration of responses that was significantly different. So for those who were responding, the duration of response is something which is very important in head and neck cancer. And that's where you could look at the figure. In the extreme regimen, 4.5 months was the median duration of response. While in the pembrolizumab, it was 23.4 months was the median duration of response. So those who responded, they kept on responding. That's again the basis of the immunotherapy that has revolutionized the head neck squamous cell carcinoma and changed the guidelines for also. And also, if you look at the duration of responses in the subgroups, again, CPS more than 20, the duration of response was 23.4 months as compared to 4.2 months in the extreme regimen. In the pembrolizumab CPS more than 1, the duration of response was 24.8 months as compared to the extreme regimen, it was 4.5 months. If we look at the treatment-related adverse events, predominantly it's the chemotherapy where you could look at 97% any grade events, extreme regimen, grade 3 and grade 5 being 69%, leading to that 2.8% and leading to discontinuation 19.9%. With Pembro, again, you look at 58.3 was the any grade events with leading to death was 1%. The immunotherapy related adverse events were common in the pembrolizumab group, as you could see 30.3%, but these were all any grade. Grade 3 or grade 5 was 6.5%. If we look at the combination group, that is the Pembro plus the chemo versus the extreme group, again, you look at those graphs, extreme regimen touching or crawling just the baseline with median PFS of around 5.1 months. But if you look at the long-term survival of these patients, so 2-year benchmark, 10% of the patients who were given Pembro plus chemo were surviving as compared to extreme regimen where only less than 5% were surviving. If we look at the total population, again, the overall survival was significantly different between the Keytruda plus chemo versus extreme regimen as compared to the 2-year and the 4-year benchmark. So hazard ratio of 0.71, meaning a 30% reduced chances of deaths when you give the Pembro plus chemo as compared to extreme regimen. And if you look at the 4-year benchmark, again, 4.5% as compared to 19.4% of those who were given Pembro plus chemo combination. The PD-L1 CPS score of more than 20 benefited most, as you could see, hazard ratio of 0.62, meaning again 40% reduced chances of deaths, 6.6% in the extreme group as compared to 28.6% patients surviving at the 4-year benchmark of the Pembro plus the chemo combination. Also, those patients who had a CPS more than 1, again 4.1% again in the TP in the extreme group as compared to 21.8% in the Pembro plus the chemo combination, hazard ratio 0.64, meaning a 36% reduced chances of deaths. If you look at the long-term data, again, the duration of response, which is very important measurement, as you could see, 6.7 months was the duration of response as compared to 4.3 months in the extreme regimen. And this duration of response was significantly higher with the CPS more than 27 months as compared to 4.2 months. And also with the CPS more than 1, I believe 6.7 months was the duration of response, and extreme, it was 4.3 months. Again, treatment-related adverse events that were 90 plus 96.9% with any grade extreme regimen, 95.3% with the Pembro chemo regimens. The immune therapy related adverse events was 25.7%, but grade 3, grade 5 was 4.5%. So looking at the safety data, the long-term follow-up confirms that it is statistically improving the overall survival, the pembrolizumab versus the extreme in the PD-L1 CPS more than 20 and CPS more than 1 population. pembrolizumab plus chemo versus extreme in PDL1, CPS more than 20 and CPS more than 1 and total population. The duration of response with pembrolizumab or pembrolizumab plus chemotherapy remained longer with extreme. Safety was also favorable for pembrolizumab versus extreme and comparable for pembrolizumab plus the chemotherapy versus extreme. So if you have to look back and look at what is the appropriate sequencing of head neck squamous relapsed metastatic cancers, I believe EMA 2012 gives a very important benchmark as also to find out whatever you're giving the first shot, whether the patients are able to take the second shot also or not. So PFS2, that is the progression-free survival in the second line, is also very, very important. And as you could look at what is PFS2, it is from the time from randomization to the objective tumor progression on the next line, which was given to it. And therefore, it is used very well when the OS cannot be measured for clinical or financial reasons, to assess the clinical benefit of the agents that do not induce responses, and to assess the effect of the maintenance therapies, and to also assess the impact of the crossover, especially when you give a strong agent second line. I believe that's where you need to find out. And that's where the keynote 48 again in ASCO 2020, when they presented the data for the PFS2 for the same study, you could look at those patients who were initially randomized with the Keytruda versus the extreme group. Again, you could look at the CPS more than 20, hazard ratio 0.64, meaning 36% reduced chances of PFS second time progression as compared to the extreme regimen, 2 years survival of 12.5% as compared to 27% with the Pembro. Similarly, for the CPS more than 1, PFS2 had a hazard ratio of 0.8, meaning a 20% reduced chances of second time progression with 8.8 months versus 9.4 months with the Pembro alone combinations. And 2 years, 22% were surviving with the Pembro. And if you look at those patients with a CPS more than 20, again, 2 years, 28.9% with the Pembro plus the chemo combinations were without progression in the second line as compared to 12% in the same. And also in the CPS more than 1, 23.7% patients were without progression in the second line with an hazard ratio of 0.66, meaning a 34% reduced chances of second time progression after the first. And also in the overall population, there was a 26% reduced chances of second time progression with a 2-year 20% plus patients surviving with the Pembro group as compared to the control arm. And also it is very important that when you give Pembro monotherapy or Pembro chemotherapy, subsequently patients were given chemotherapies and the EGFR inhibitors in the second line. And when you give extreme regimen, you could look at the immune checkpoint inhibitors, around 16.7% were able to receive immunotherapy second line. So to conclude, Keytruda significantly improves the overall survival as compared to the extreme regimen in a PDL1 CPS more than 20 with an hazard ratio of 0.61 and a CPS more than 1 hazard ratio of 0.78, meaning a 22% reduced chances of deaths. There was no PFS benefit for Keytruda, but that's not how the immunotherapy studies are designed. Although Keytruda has a lower response rate, responses were substantially more durable. So duration of responses was much, much higher. The Keytruda monotherapy was versus extreme regimen. The PFS2 was longer for the Keytruda arm in patients which were PDL1, CPS more than 20 and CPS more than 1. The PFS data further supports the use of Keytruda as the first-line treatment of relapsed metastatic head neck squamous cell carcinomas. Keytruda has a favorable safety profile as compared to extreme. There is a lower incidence of any grade 3 or 4 and grade 5 treatment-related adverse events. There is a lower incidence of treatment-related adverse events leading to discontinuation. And data does support that Keytruda monotherapy as a new first-line standard of care for relapsed metastatic head neck squamous cell carcinomas that expresses PDL1 for them. Keytruda plus chemotherapy with a platinum or 5-FU significantly improves the overall survival as compared to the extreme regimen in the total population with an hazard ratio of 0.77, meaning a 23% reduced chances of deaths. There was no PFS or overall response rate benefit for Keytruda plus chemotherapy. Responses to Keytruda plus chemotherapy were, however, more durable. Keytruda plus chemotherapy versus extreme again showed that in those patients with a PD-L1 CPS more than 20 or 1 and total population, the PFS2 was much longer. The PFS2 data further supports as the first-line treatment for the relapsed metastatic head and neck squamous cell carcinomas. And if you look at the safety profile, it was comparable of combination of the Keytruda plus chemo versus the extreme regimen. And therefore, we can say that Keytruda plus platinum-based chemotherapy as a new first-line standard of care for relapsed metastatic head and neck squamous cell carcinomas. Thank you for your patient listening and would love to answer any questions if there are any. Thank you.
Thank you, Dr. Vikash, for the nice presentation. Really, the metastatic head and neck squamous cell carcinoma is a bad subgroup, but there needs to be something that is done to shift the curve up. Any questions we would like to take? Okay.
Just off the record, MSD is here, so I'm scared to ask this question because April I'm going to organize Icon. So off the record, MSD guys. So Vikas, yesterday Dr. Amol was talking about flat dosing versus weight-based dosing. So do you feel that there is unmet need for this, especially in our country? Because we have data of TMH where low dose immunotherapies, they are working well and we have practiced it. So